Throughout this panel, we'll explore what issues gay and bisexual men face when accessing mental health care. So the speakers are sort of sitting in orders, and so I'm going to introduce everyone before they start speaking. So we're a little bit tight with time, so each speaker will speak about for 10 minutes, and we're going to have 20 minutes shared question period at the end. Okay. Dr. Paul MacPherson is an associate professor of medicine at the University of Ottawa, a specialist in infectious diseases at the Ottawa Hospital, and a clinician scientist at the Ottawa Hospital Research Institute. He has an active practice in infectious diseases with a focus on HIV and holds a OHTN research chair in gay men's health. He will be presenting on the experiences of gay and other MSM living outside of the urban metropolis. Robert Ortiz is an executive director of Max Ottawa. He has previously worked at Réseau Santé in Montreal as the research and development officer. Derek Cassidy is the mental health and wellness coordinator of Max Ottawa. He's responsible for the mental health navigation service and other wellness programming. Roberto and Derek will be presenting on their work around navigating services and partnership in Ottawa. Dr. Barry Adam is a distinguished university professor emeritus of sociology at the University of Windsor and senior scientist at the Ontario HIV Treatment Network. He has an extensive record on the dynamics of domination and empowerment, LGBT studies, HIV prevention, and issues of living with HIV. He will be presenting reasons for why we need more syndemic approach to syndemics in Toronto. Mark Gaspar is a postdoc fellow at the Dalla Lana School of Public Health. He is working on 3 national gay men's health studies, including HPV SAVE, Engage, and a Canadian blood service study. He will be presenting gay and bisexual men's experiences accessing mental health services in Toronto, the preliminary findings from the Engage qualitative study. Aaron Purdie is a registered clinical counselor at Eagle Wellness and Keep the Wild, and program manager for mental health programs at Health Initiative for Men in Vancouver. Aaron is involved with local, provincial, and national projects dedicated to mental health promotion. He will be presenting on centering the margins at Health Initiative for Men in Vancouver. Please join me in welcoming these panelists.
All right, good afternoon. All right, this is going to be way easier with slides. Because I was like, I don't remember any of the data. So as Eugene said, I'm actually a physician. I've been practicing really in HIV care for over 20 years now. But my main clinical and research interest is in gay men's health. And by health, I mean their physical health. I care about their cholesterol and their blood pressure, in their sexual health. And I don't just mean HIV treatment or prevention. I mean in terms of their sexual satisfaction, in their mental health, dealing with anxiety and depression, and in their social health. So I want to see a full, comprehensive approach to gay men's health in the province. So in setting out to do that, though, it became very obvious we have to know about the people we're trying to deliver health care to. We need to know what they want and what their healthcare issues are and how they want their healthcare delivered to them. So in order to do that, we actually did a survey. These data are a couple of years old now, in the Ottawa region. And the purpose of the survey was to focus on their health. So this was not a survey to ask them how many sexual partners they had, how often they used condoms. This was asking them about their health, how much they were engaged in healthcare, and how they wanted their healthcare delivered to them. The survey we did in both English and French, being in Ottawa, it was anonymous. Most of them completed the survey online. We did have some paper copies in some clinics so people could fill it out while they're waiting to be seen, like at the sexual health clinic. And we broadly promoted this mostly through community networking in Ottawa. We targeted the Champlain LHIN, which is our LHIN in Ottawa, which you can see I've marked out there in the eastern part of the province. What's particularly neat about the Champlain LHIN in this regard is that in the center of the LHIN is Ottawa, which, as you know, is a city of about 1 million people. We know where Ottawa is. We know where South Ottawa is. Everybody asks, well, if you have South Ottawa, where's North Ottawa? North Ottawa is actually known as Gatineau. So we have a very francophone part of the city. But outside that center part, I don't know if I have a pointer here. Anyway, outside of the center of a city of 1 million people, we're surrounded by small cities. To the west, we have Renfrew and Carleton Place and Arnprior. And to the east, we have Hawkesbury and Cornwall and Winchester. So we have people living in both an urban core. We have Canada and Orleans and Bell's Corners as suburbs, but then we are surrounded by small towns. And so that became of interest in, I hit it, my slides freak up. Became of interest in knowing how different guys were experiencing healthcare in different parts of the region. So in terms of our data, we had 674 respondents. The average age was 44, though we had 18 to 83 years. Just over 60% actually lived in the urban core, but nearly a quarter lived in the suburbs, and about 15% of the guys actually said they lived in the small towns surrounding the city. So if we look at some of the demographics by region, the guys living outside the urban core actually were older. So of the people over the age of 40, and I'm well over 40, but anyway, 80% of the guys living outside the urban core were over 40, whereas only 50% of the guys living downtown inside the urban core were over 40. So we're seeing a slightly older population outside the city. And you'll notice more men are identifying as bisexual. So in the urban core, only 12% of guys identified as bisexual, but over a third outside the city identified as bisexual, so slightly older and more likely to be bisexual. I know this is about mental health, but physical health affects mental health, and mental health affects physical health. So a little bit about that. In terms of their physical challenges, we saw more cancer, more cholesterol, high cholesterol, and more heart disease, probably reflecting, again, the older age of the guys living outside the city compared to the younger guys living in the urban core. And in terms of HIV testing, guys living outside the city test less. So only 5% of guys living downtown have never had an HIV test, and 2/3, or nearly 2/3, have actually had an HIV test within the last year. So fairly high testing rates. But once you move outside the city, 12% of the guys had never had an HIV test, and just over a third had tested in the last year. So these guys are not testing as much. In terms of mental health, there actually wasn't a lot of difference. So in our survey, we embedded the PHQ-4, which is a validated testing or screening tool for depression and anxiety. And then using that tool, we were able to look for the prevalence, at least based on screening. So a little bit more depression, or people screening as likely depressed outside the urban core, but not a whole lot different. And anxiety really wasn't changing across the different parts of the city. However, when we also asked them, have you ever actually been diagnosed? Have you received a diagnosis? And you'll see there's a decrease. So people living outside the city weren't getting diagnosed, so probably not actually even seeking mental health care. Also, in terms of who they were out to, if you're not living downtown, you're less likely to be out. So only 4% of guys living in the urban core were out to no one, whereas nearly a quarter of the guys living outside were out to no one. And that included family, friends, and their co-workers at work, much, much less likely to be out. And that also included the primary care provider. So whereas 17% of the guys living downtown were not out to the primary care provider, 40% of the guys living outside the city had not disclosed their sexual orientation to their family doctor. Sexual satisfaction, so being satisfied or somewhat satisfied with their sex life actually decreased as we left the city, and conversely, their dissatisfaction increased as we moved out of the city. And sexual anxiety, though, was about the same. Alcohol use actually increased. So using Health Canada's definition of more than 15 drinks a week as being problem alcohol use, that nearly doubled as we went from the core out into the small towns. although still less than the general population, you'll notice. The general population is about 14%. However, so-called illicit drug use was actually the reverse. So there was more drug use in the urban core and less drug use by half when you moved out into the small cities. So less cocaine, about the same methamphetamine, less ecstasy, and marijuana was like everybody's smoking. Okay, not everybody, 30%. But so alcohol increased as you left the city and moved out, and drug use decreased as you left the city and moved out. So in summary, men who have sex with men living outside the urban center tend to be a little bit older. So again, 80% were over the age of 40. They were more likely to be bisexual, up to over a third of them. They were less likely to be out, including to their family, friends, and coworkers. And they have, not surprisingly, more age-related health concerns, specifically cancer and heart disease, but they were much less likely to actually seek testing. I didn't show the STI data, but it was the exact same as for the HIV. They were much less likely to seek testing for HIV and STIs. And those guys living outside the urban center, there was this pretty similar point prevalence for depression based on screening tools and for anxiety, and a similar prevalence of actual sexual anxiety. But they were more likely to be dissatisfied with their sex. Up to 40% of guys living outside the city felt that their sex was not what they wanted it to be. They were more likely to use alcohol and less likely to use illicit drugs. So I think my message is gay guys across the geographic spectrum are not the same. So we have a big province, and when we talk about delivering health care to gay men, we have to remember where we're delivering the care to and what their lives are like in that geographic area, among other things, right? But when we can't just design programs for guys living in the urban core. We have to learn how to deliver health care to guys outside, whether it's just outside Ottawa, in Perth, or whether it's in North Bay, or whether it's in Thunder Bay. Delivering health care to people in different places we need different approaches. It is not a one-size-fits-all approach. Thank you.
Hi, everyone. So Derek and Roberto from Ottawa. We're at the Ottawa table today. We come from Max. Who is Max? So we're the former Ottawa Gay Men's Wellness Initiative, which is a community-based organization by, for, and with gay, bisexual, two-spirit, queer, and other guys who are into guys, whether cis or trans. We are very proud to be the first standalone LGBTQ men's health organization in Ontario, and our approach is one of holistic health, so sexual, mental, social, physical, and spiritual health and wellness. Today we're going to focus, because most of the work we've done over the past 2 years is around mental health. So what does Max do? We help guys into guys maximize their health. We get them connected to competent mental health services, which is what Derek and I will talk about today. But we also have a very strong commitment to connect guys through community activities. So whether it is community activities that we'll create with them for them, or that they'll bring their own ideas and we'll support them to make them happen, or just making sure that people are aware of all the community activities and opportunities in the city.
All right, so we're going to be speaking about one service and then the partnership table that we host. So I'm going to be speaking about mental health navigation. So mental health navigation seeks to connect guys to competent mental health services. And I'll get into how we set it up and what that looks like in a minute. This is the process. So when someone is looking to see a counselor, a psychotherapist, a social worker, or a psychologist, or any sort of like community groups or support groups, they can make an appointment with us through our website, through online apps that we're on, so like Grindr, Scruff, Hornet, or they can call in, and we do an intake. So it usually takes about half an hour to an hour. We figure out, what their needs are, how much money they have to spend, if they have insurance, what part of the city they're in, and sometimes we, like, if they have all of these things going for them, especially insurance, like what sort of like personality they're looking for in a counselor. So, and if they have a gender preference, if they have, sometimes, this one's really hard, we'll talk about this in the challenges, but like counselors of color, so sometimes people are coming in who are experiencing racism and would prefer to be with someone who's a counselor of color who would get these things based on personal experience. The second thing is the referral. So usually within the next couple days, I talk about this in the intake with them a little bit, but I send them a list of referrals that might be that might work for them. So I list the pros and cons. I try to get something that's in the same area that they're in, so that people aren't having to travel to like from one suburb to the other, or if they're downtown, traveling like way out of downtown to find something. When we're talking about accessible services, so services that are pay what you can, sometimes that's unavoidable if we're looking at wait lists and stuff. And then we follow up. So we follow up in 1 to 2 weeks just to make sure there was a connection made to the service. And then we follow up again in 3 months just to make sure that everything went well and that it was a good fit. And if not, we offered to start from the beginning and like set them up with someone else. And sometimes we just like don't hear back from people, so that's another reality, which I hope just means that everything went well for them. So how did we set this up? So there were a couple things I wanted to say that aren't on here. What we wanted to do was kind of like set up a network of counselors that we felt comfortable referring out to, and that every referral that we made was a warm handoff. So we started with a group of people that we kind of like trusted and knew and had worked with in the past, either through like jobs that we had done in the past, or either through people that we had worked with in the past in other positions, or people that were like close to the Gay Men's Wellness Initiative, which was what Max was before as a community group. So from there it was either people that recommended counselors that they had worked with, counselors that we were referred to by people in our network already, and I would set up appointments with them. So when I first started working with Max, I would set up appointments with them for about an hour, and I would kind of go through a checklist. So looking at like what people's connection to the community was and how they're connected to the community. So most people are either like part of the LGBTQ plus spectrum, or have some sort of connection, have worked with folks in the past, queer folks in the past. Sorry, I just got like distracted by the like 5 minutes left. Yeah, and then also things around like accessibility. So making sure that like if we're referring someone that is using a mobility device, that they can actually like get into the office, and like practical things like that. So like bus stops, etc. Then, yeah, consultations with community and partners. So we just started referring out to people and getting feedback on. So we started with a small group and we would get feedback from like people that we would refer out. So sometimes it'd be like, okay, like this person was referred for this topic. How did it go? Okay, maybe like they're good on these topics, but maybe not so much on this. So it's finding out like what people are competent in, because just because they're queer and they work with queer people doesn't necessarily mean that they're strong in like all of these areas. So that's good for us to know. And then, Roberta's going to speak about the partnership table, which involves most of the people that are in this network, but working from a more structural and systems level.
So something that from the beginning we put in place was a mental health partnership roundtable. We realized from the needs assessment before setting the service, from the Ottawa Hospital survey and other research, that there were some gaps in services. So we wanted to make sure that we weren't only offering the navigation service, but that we were already also starting to look at the reality on a more structural level. So just like Travis was mentioning in the beginning, these roundtable idea, that's what we set up as well. So we've been having the Ottawa roundtable for a year and a half. We hold meetings quarterly, And who is included? We have some private practitioners. We have agencies that offer mental health services or that have a mental health mandate, like Ottawa Public Health, and other agencies that work with guys who are into guys. So we have over 15 agencies that sit on the table. They don't always all come to all the meetings, but that those meetings and those partnerships have helped us also address some of the gaps that we have identified. For example, we had identified, we were told that there were difficulty looking for services around intimate partner violence and sexual violence for guys into guys. So we are not intending on putting and starting everything from zero in-house at Max, but like there's the Counseling Family Services of Ottawa who have developed an expertise in the subject, but not for guys into guys. So we, thanks to that partnership roundtable and work that we started, we're going to start in the next fiscal together bringing their experts in that area with our expertise, reaching out to the community and together co-facilitating and offering support groups around intimate partner violence for guys into guys. So that's an example of how these partnerships are important to address those gaps and not starting from zero and taking what everyone's expert on. So that's one of the ways that we're addressing systemically to respond to those issues.
All right, I think we have like a minute left, so I'm gonna go through these quickly. So some of the things that we're working on going into the next fiscal is motivational interviewing and short-term peer counseling. Support groups, so we have 4 support groups that were developed by ACT that we're going to be implementing, and if you were at the group with Robert and Matt earlier, they were talking about our Community Maximizers program, which one of our first pilots from that was an ACB queer and trans guys into guys support/social group. We'll be doing short-term peer coaching, and other things that we're talking about are walk-in counseling, so we're working on another center for that, working with another center for that, and online coaching, which we're still trying to figure out. Some of the challenges that we've faced are like things that have been mentioned like throughout the day. So obviously developing partnerships takes time. Long wait lists for free or affordable services. So we've seen like sometimes the shortest is like 6 months. They can go up to like 2 or 3 years depending on what you're looking for, and especially depending on the severity of the case. Lack of diverse profiles of healthcare professionals. So like I was saying, counselors who are people of color, finding referrals for our trans clients has been a bit of an issue, although we've kind of sorted that out a bit. Yeah, so we're working between, as Paul was saying, Gatineau and Ottawa. So sometimes we're a little bit unfamiliar as to like how things work in Gatineau and like finding people and connecting them. But we try to just reach out to other social services and service providers there that can kind of do navigation on the Gatineau side. And that's us. Oh, the other thing I was going to say is we left. I left some cards of ours on the table outside that has some information about the navigation service. It's really quick. It's just like 1, 2, 3 how it works and our contact information on the back. But just to give you like an example of the things that we distribute to promote it. Thank you.
All right. First of all, thank you all for holding up until after 4 o'clock. It's been a bit of a long day, and it's great to see this turnout for the last panel. What I want to talk about this afternoon is some of the thinking that went into why we called this conference together and where we might go from here. So the we is the Gay Men's Sexual Health Alliance and the Ontario HIV Treatment Network. And both of those organizations, of course, have a strong HIV mandate. And so my starting point here is just to look at the latest figures from Ontario, where the gold bars you can see are the number of new HIV diagnoses among men in Ontario since 2007. And you can see over the last 5 years that we really haven't been making progress. The rate has pretty much plateaued. And really underneath that rate, in fact, is an uptick in HIV infections among gay men under the age of 35. So that's not a good sign. So here's the breakdown by priority population, and the bars on the left are gay, bi, men who have, and other men who have sex with men. And the latest figure there is 58.8% are still happening among our population. So, what does this have to do with the conference on mental health? Well, it turns out it has a huge amount to do with that. There are clearly biomedical solutions that are critically important for HIV infection, but it's not the whole story. So this gets back to syndemics research, which Travis introduced us to this morning. And that is that vulnerability to HIV infection is strongly associated with a few factors like substance use, and in gay communities, particularly a set of club drugs and crystal meth especially. It's also associated with a history of childhood trauma, such as sexual abuse, homophobic and racist bullying, intimate partner violence, and depression, all themes that have been coming up already throughout today. And that was summed up, there's a huge amount, 30 years of research now into these factors that show how strongly they do predict seroconversion, and they are ultimately summed up by Ron Stahl and colleagues in the term syndemics, which just means that a lot of gay folk are at the intersection of multiple epidemics of substance use, childhood traumas, depression, and so on. Now, in the social sciences, we're not used to very strong predictive factors, but when you look at syndemics, they have quite surprising ability to predict health problems like HIV, seroconversion. And this research by Memiaga and colleagues in the US shows that it's a cumulative effect. So those who show two of these conditions, and the conditions are described there as depression, alcohol use, stimulant use, polydrug use, or childhood sexual abuse. Those who showed two of those conditions had a 2.4-fold increased risk. Those with three, a 5.3-fold increased risk, and men with 4 or 5 of those conditions had an 8.7-fold increased risk of acquiring HIV over a 48-month period. Those are remarkably strong predictors. So in other words, it's not just going to be biomedicine that's going to address those HIV numbers. It's going to take mental health interventions as well. And I think it's important to say, so those are seroconversion outcomes, but among people who are living with HIV, syndemic factors continue to affect their health as well. So they predict lower adherence to taking HIV medications. They predict having a higher viral load. They predict higher rates of condomless sex, and they predict higher rates of HIV transmission. So syndemics issues remain important for both negative and positive folk. I do want to say, since we said a lot about syndemics, that syndemics, of course, is not an isolated thing. It exists in a larger context, and that's not to neglect other kinds of issues like social determinants of health, migration issues, intersectionality of where people are located in gender spectrums, racialization, and so on. And there's a whole research literature on adverse childhood events that applies across the board, certainly not just to gay, bi, MSM, that also predicts similar kind of more negative health outcomes. So here's a repeated theme. By now you've heard this story quite a few times, and here's yet more evidence. We have access issues to the health system that need to be remedied if we're going to have an impact on HIV numbers and on access to mental health services as well. And these 3 studies that I'm studying are all Canadian-based. The first one comes from Sex Now that you've heard from. The second one out of OHTN just points out that almost half of the men studied lacked a family physician with whom they felt comfortable addressing their sexual health. And a recent study by Hoskin looking at LGBT people in general that points out that issues of confidentiality, fear of facing prejudice or ignorance from the medical system and physicians, and the possible consequences of not having their health needs met were primary concerns that limited access in the first place. And that study had a comparison with straight people, and they didn't have any of those concerns. Their concerns were, what's the result of my test? So it really shows, again, and repeatedly we've seen from several speakers, we need to be able to address access issues. And those lack of access issues do have real effects. So there's research done on the sexual health of gay men that's pointing out that it means some basic things like they're not tested for STIs in the right sites. And if they're not being tested in the right orifices, they're not, their sexual health is not going to be as good. And it's also going to help facilitate HIV transmission. Citing Paul here, in the first one, you've heard Paul's study. And we found as well in evaluating an HIV testing campaign that we did a few years ago here in Toronto, that we found that gay men were willing to travel a considerable distance to access care they perceived to be gay-friendly, even bypassing clinics that are closer to home and work in order to get testing. So where do we go from here? The argument I want to make is we need a gay-friendly, or even better, an LGBT health center in Toronto. And they exist in other places, in major US cities. Ottawa is making tremendous advances that we can learn from. And I think it's time that we get more organized. So there are biomedical solutions. We do need way better PrEP access in Ontario, for example. BC's got a program. Quebec already has pharmacare. For some reason, Ontario is a laggard in this area. We need to move on the biomedical front, but everybody in this room is part of the solution too. Mental health services are going to be a critical part of the answer, and we need some kind of gay-friendly point of entry that assesses people for syndemic conditions and does a better match between the need and the services. There are services here, look at all of the talent and labor in this room that are delivering excellent services, but it's not always well connected to where the need is, and we've got access problems. So Fenway's been mentioned already. Fenway is a clinic, actually an amazing 10-story building on the west side of Boston, where they've got it all. They've got primary care, they've got mental health care, they've got research. And when you walk through the door, basically there's a health navigator there that does a holistic health assessment, including checking off if you've got syndemic factors happening in your life. And they just refer you to, you should check out floor number 6, floor number 8, right? And so whatever the physical or mental health need of yours is, they've got you tracked. There are others in the U.S., Strutt in San Francisco, Whitman Walker Clinic in Washington, D.C., Howard Brown Clinic in Chicago. And in Canada, we've got some initiatives. We're going to hear from him shortly, which is, I think, a really interesting model. We just heard from Max, And even little old Winnipeg, dare I say, has a clinic, a dedicated clinic called Our Own Clinic, which is a gay-friendly clinic that you can go to for services. Somehow, I'm not sure how Toronto didn't manage to arrive there. But this is where I'm going to end, and that is to say that my bottom line there is our motivation in working in the HIV field is that HIV is never a single issue. HIV is just an index to a whole bunch of other issues, physical health issues and mental health issues. And if we're going to make any kind of headway in bringing gay, bi, MSM to an equitable health standard that the rest of the population can take for granted, we're going to need to have a systematic response. And we're inviting you all to be part of making that more systematic response to the mental health and addictions needs. So thank you.
Hello. I like the way Travis had opened about acknowledging the anxiety that goes in presenting, which is ironic in the context of a mental health summit. I used to take beta blockers before I spoke in public, but then before a big talk, I looked in the mirror, my pupils were this big, and I was kind of high. And Barry said my talk was really good. I don't remember what I said. Not on beta blockers now. I actually don't need to go into the background because Travis did a beautiful job of highlighting this research, and so did Barry. Basically highlighting the mental health disparities among GBMSM and its links to HIV. So I'm not going to repeat it. I'll come back to this research in a moment. But in addition to research, there's also this growing popular discourse on a mental health epidemic among gay, bi, MSM. And I'll just do a little plug, I'll come back to this, that this issue of mental health, although it affects gay men in particular ways, is not just happening among gay men, that there is a broader conversation happening in general among multiple populations about mental health, and we could actually see this as an opportunity. I'll get to that in a moment. So factoring in all these things, my research team, and I'll explain the research project a bit more in a moment, but this is part of the ENGAGE study. We decided to focus on these two research questions. The first is, how are GBMSM making sense of their mental health and mental health needs? And what are GBMSM's decision-making processes and experiences accessing and receiving mental health services and supports? So those were the starting questions. How we did this is the qualitative component, which I was leading with Daniel Grace. We recruited through the National ENGAGE study, which is using respondent-driven sampling in Vancouver, Montreal, and Toronto. And if you don't know much about the study, please speak to me more, or Trevor Hart, or Ricky Rodriguez. And basically, participants who completed the ENGAGE study, which included a survey and a biomedical screening, they were asked, there was an extra email recruitment, if they were interested in talking about mental health and their experiences accessing services. And those that said yes, they came in and they spoke with me. I did 24 active interviews. I'll explain what I mean by active in a moment. These were all based in Toronto, despite the fact that the study is national. We're thinking of pilot studies in Montreal at the moment, and they were analyzed in vivo using grounded theory. So these are the interview domains. The first was just going over the guys' current mental health state. The second was their experiences with mental health-related challenges. The third was their experiences accessing mental health services and supports. Their fourth were their experiences with substance use and accessing supports for substance use issues. And their fifth were their experiences managing sexual health and HIV-related health. Active interviews, though, are not really structured interviews. So despite the fact that these are categorized in these different ways, it's just a way to explain it to a broader audience. I actually, the goal is to follow the participant's speech. So a lot of these things are kind of mixed in together because they're not particularly siloed. And what I can say is I've done quite a few qualitative interviews, but these were some of the most difficult I've ever done. It was listening to a lot of pain repeatedly. And I'm saying that acknowledging that this is the work that so many of you do in this room daily, and that you should be very proud of that type of work, because even just doing it for 2 months, it was really exhausting. Just going through some quick demos. So we had a bit of diversity. Our age group, we had quite a few within the 30 to 40 range. Our sample leaned a little bit white. We had mostly cisgendered men in our sample. We spoke to one trans man and one gender non-binary man. In terms of HIV status, we had 9 HIV positive guys, of which 8 were undetectable and 1 were detectable. And we had 7 that have taken PrEP or were currently taking PrEP of the guys that were HIV negative. So 2 initial analyses trajectories. I'm going to focus on the second, but the first is just that focusing on the difficulties of accessing mental health services in Toronto. And the main thesis that we're working through, because this is preliminary, is that the experiences of accessing mental health services and supports can be so stressful that they actually aggravate the very anxieties and depression participants were seeking to address. So just kind of interesting that we're saying you should seek support, but in so doing so, it's actually causing the problems that they're seeking to address. There are numerous complex barriers to entry, including cost and trauma. I'll do a little plug around the trauma associated with psychiatry for many of our participants, and a lot of underwhelming service experiences. I really need to go through ahead. So this presentation is mostly going to focus on the evolving landscape of HIV prevention and treatment on mental health. So a lot of participants spoke optimistically about the benefits of PrEP and undetectable viral load on their health, and spoke about this as a combination. So there's one quote right here. But I think with PEP and PrEP, and now the undetectable thing being uninfectable or untransmissible, I think things have changed. And this was something that was repeated throughout all of the interviews. So what we noticed was 2 contradictory kind of narratives. One, HIV medications discussed as having positive effects on mental health, but 2, HIV medications also positioned as having limited capacities to address mental health. So it's important to think about these 2 things as working together. So in terms of positive effects on mental health, I'm just going to go into the actual quotes. So some made a separation between their HIV-related health from their mental health. So this is a person living with HIV. Well, I don't really talk too much about HIV with my psychotherapist. I'm talking more about why I have bad body image, why, I panic at work sometimes because I think I'm in trouble and I'm going to lose my job. And this was the participant who had the previous quote. So simultaneously, we're in a new era of PrEP and undetectable viral load, and HIV is not the main thing that I'm actually stressing about. There are other things that I'm worried about. With this PrEP user, a huge weight was lifted off my shoulders. I have more control. I have more agency over my sexual health. I have more empowerment. I'm not scared anymore. And with this PrEP user, and this is particularly interesting, so similarly, I can say right off the bat that I used to be a lot more anxious about sexual health before I started PrEP and before I started seeing a doctor regularly. I would say that seeing my doctor regularly actually is more comforting to me than the PrEP itself. And I think this is important. It highlights what Travis had said earlier, where what is actually happening is that in seeking a sexual health service, it's actually talking that out with a professional that is having effects in addition to the actual benefits of PrEP. But it is important that we focus also on how PrEP and undetectable viral load and treatment had limited abilities to affect mental health. First, mental health is not reducible to sexual health or HIV-related concerns, and we've heard that repeated throughout the conference by different people. PrEP was not considered a suitable strategy by some. So while it's beneficial for some people, if it doesn't make sense for others, it's not going to affect their anxiety or depression. Third, we saw in the sample continued anxiety over sex despite knowledge about PrEP and undetectable viral load, continued stigma and shame associated with living with HIV, and mental health-related side effects of HIV medications. So a lot of people talked about nightmares and reduced sleep, which actually affected their mental health. So this is a PrEP user when asked about PrEP's effect on his mental health. Neutral. I'm glad I went on it and I've learned some things and done some new things. I think being on PrEP helped me enjoy bareback sex more, but I wouldn't necessarily say that I was doing anything for my mental health. And going back to what Raheem said, we have this heavy focus on, when we're looking at GBMSM on sex and on sexual health, that we think that PrEP might be a grand solution, but this guy's saying, no, it didn't do anything for my mental health. I'm not going to read this quote, but this is a person who's on PrEP, and is talking about his fears, not just around having serial variant sex, but actually having anal sex in general, even with HIV-negative men, despite knowing about undetectable viral load. And he talks about being a child of the 90s and the fear that he has. So even though he rationally understands these solutions, it's actually not enough to address his anxieties and his fears. And in fact, his ability to not be sexually free now that he's on PrEP is causing him to have additional anxieties and shame. This is a participant living with HIV. He talks about how he's HIV positive and his HIV-related health, he's undetectable, his viral load counts are all great, but his mental health is, it's up and down. So we see this disconnect around the fact that even though his HIV-related health and he has an undetectable viral load is there, that's not really affecting the other sources of stress in his life or the things affecting his mental health. The other thing that's really important, and goes to the talk that John had this morning, was this disconnect is actually interesting because this participant spoke about how, so he made this disconnect between his HIV health and his mental health, but he also informed me that he hadn't told anybody, about 4 people he's told, that he's HIV positive in 24 years, right? Which shows that there's some stigma and shame that he's not associating necessarily with his mental health, but we could think about the implications. And lastly, these are 2 people who I would say have a syndemic profile, who talk about being undetectable and talk about the benefits of U equal U, but also talk about how they're not dealing with their HIV diagnosis that well in terms of their psychology, and they're still dealing with internalized stigma and shame. And this is because even though their HIV-related health, they rationally understand it as fine, going back to what Barry said, their HIV diagnosis signify part of this broader kind of syndemic profile, abuse, going through the refugee claimant process, sexual violence, etc., that they've not yet dealt with. So what are the implications? Very quickly. The first, this is important, and this goes to what Barry said, access to an increased discourse on new treatment and prevention options can have longer-term positive benefits on GBMSM's mental health and well-being. I think that's an important and exciting finding. However, this story is not that simple. The long-term effects of the epidemic on mental health remain, so even when we have PrEP and undetectable viral load, the effects of HIV on our communities are still going to exist. Very importantly, HIV is not the sole cause of these men's mental distress. The sources of trauma and stress are multiple and complex, and and we've seen this in different presentations, but economic precarity, the rising cost of living, in addition to minority stress and abuse, and this is what relates back to what I was saying before about it's not just gay men. Yes, we can offer counseling, but we also have to offer critiques about how capitalism is corroding the health of all people. And so we want to give them counseling, but if we don't actually talk about how we're overworked and overstimulated and underpaid, we're actually not going to address this problem at all, even if we address HIV and minority stress. And so I'll just leave it with the last point, which goes to this, is that since these issues are complex, the solutions we offer to remedy our mental health epidemic must also be multiple and complex. So thank you.
Hi, everybody. How am I the last, thing of the day? Thanks to Dane and Ryan for allowing me to come and visit from Vancouver, from Coast Salish territories. I'm grateful to be here. I'm coming and speaking to you from the perspective of primarily my role as a program manager at Health Initiative for Men in Vancouver. But I'm also a clinician in private practice, so I have 2 private practices. And I've really been reflecting today about how enjoyable it is to be in this space and how honored I am to get to work almost exclusively with queer people. So today I'm going to talk about some of the work that we've been doing at HIM to kind of move an agenda forward of centering the margins and what that looks like. I'm going to admit to not being perfect. Hate to admit it, because I strive for the fictional thing called perfection. But, it's unachievable. So here we are. So I'm going to talk to you a little bit about some of how I've kind of conceptualized some of the changes that we've made at HIM, and then leave it at that. Also, kind of worked perfectly because my colleagues kind of front-loaded you with all the things, and then I get the simple presentation. So thanks, guys. So we're obviously operating on the understanding that we do understand that there are organizations that exist, bodies that exist that actually do serve population specific. So there's the classic, there's the AIDS service organization, there's women's organizations, there's organizations and authorities for trans groups. So these are generally organizations that function within the large, straight sphere of everything, but they carve out space for usually one group. So sometimes there are organizations that are usually, criminally underfunded that kind of focus on those intersectional pieces, but we'll talk about that. So usually these organizations look like the organizations that I've listed. In our context, in Vancouver, we were born out of that same kind of information that was shared about syndemics. A complicated problem requires a complicated solution. At HIM, we frame things in the positive. We try and stay focused on benefit maximization, mutually beneficial relationships, peer-based supports, but really we are a gay men's health organization. And I should say that the caveat, and it has expanded, we at first were like, we are for gay guys. But as we existed, we realized we needed to define that and expand that. So at this point today, 2018, it also refers to non-binary folks who like our supports. It refers to trans women who are more comfortable with our supports than other places. It refers to sex workers. It refers to cis guys. It refers to trans guys. It refers to guys who don't identify with anything. So at this point, that's who we are. And we're always growing and evolving. So I will also just say, we've done some unique mental health promotions, so if you all wanted to check out another thing that I didn't put in these slides, but I'm gonna reference, if you mark down checkemout.ca/mind, M-I-N-D, that's our mental health promotion website. So I'm gonna touch on it, and then y'all can check it out if you'd like, or not, whatever, I'm okay with it. I'm gonna talk briefly about mental health programs at HIM and kind of where we've been going. So when the organization started, the kind of original ED made this kind of request to say, let's get some mental health programs started right from the beginning. I should go back. Those icons represent the 4 pillars that govern our work. From left to right, we've got physical health, sexual health, social health, and mental health. The idea is we have programs underneath all of those buckets or pillars, but also we try and intermingle all of the different functions within that, within all of those different, under those different pillars. Can we be under a pillar? Whatever. So the Volunteer Professional Counseling Program was the first counseling program at HIM, and that program leveraged volunteers, primarily retired social workers who wanted to do more kind of clinical work, and they were like, I'm kind of bored in retirement, so I'm going to do this. Some of them were psychologists who were just interested in giving back to their communities. Some of them were clinical counselors, similarly interested in working in a gay space. They never had that opportunity, so they wanted to volunteer and do that. So we offer kind of brief solution-focused interventions. Previously, this was really the only clinical counseling, really the only clinical program at HIM, other than the testing and treatment, which is something we host, promote, and support, but we're not the nurses, so we do not employ nurses. We create the space. Previously, this was the only counseling program at HIM, but it has been recently adapted to prioritize guys with low income as well as guys from marginalized groups. And I apologize to the people who were in my workshop earlier because it's a little bit of a replay. I apologize. We also have a peer-based coaching model that trains peers who are interested in working with guys one-on-one. They're listening, they're doing active listening, they're doing a little bit of motivational interviewing. And that's kind of we call it our ultimate lifestyle solution. Maybe you want to balance your finances, change a job, go back to school. You need an assistant to help you get motivated and set goals. That's what that program's all about. We're also highly accessible in that program in that we can call people on the phone, we can visit them at home, and we can kind of do it from remote in our space. So going back to the organizational structures, within these organizations, usually The habit is to cluster the programs around the center. Interestingly, the way I'd like to frame this for you is actually that the gravity is lightest in the middle of the center of that circle. And yet, as you can see, there's people mapped out all around the circle, but the programs tend to be clustered towards the middle. But we know that there is a margin, that for many different factors and many different reasons, the people, based on their being marginalized, whether it's income, poverty, developmental disability, physical disability, invisible disability, gender, mental health status, it could be the color of their skin. We know that those factors contribute to marginalization, and yet for some reason the programs still tend to be clustered towards the middle, essentially positing that all the people on the margins have a longer way to walk to get to the middle, against a higher pressure of gravity, which is pushing them to the outside. So we're asking people to kind of all access the same services, all access the same supports as if they're equitable, but they're really not. The hypothesis is equality, but that just stopped working for us. What's next? So what is the need? The need started coming to us in a number of different ways. And when I say us, I mean myself and the Mental Health Advisory Committee. One of the sources was saying, the counselors were saying, why is it that I'm seeing clients who make more than me per year? Good question. We were hearing feedback from other sources, from other communities saying, we need space. We need to be recognized. We need to be seen and have space that's unique and created for us. These are two documents that came from the Community-Based Research Center for Gay Men's Health in Vancouver. And I'm going to show one of the slides soon. But the Speaking Up document was actually a note and condensation of information from a community consultation with QT BIPOC, so queer, trans, indigenous, mixed, people of color, who were saying what they wanted from queer spaces, what they wanted from queer organizations. The other one is some things that Travis has already talked about. So the information is there. One of the most powerful things for me was in another presentation that I saw that Travis did was these data. And as you'll see, the proportion of people reporting a suicide attempt in the past 12 months is shockingly higher if income is lower. I see this as cold, hard facts, and it was time to make the leap. So essentially what we did is we created, in an effort to kind of not disrupt what we'd already created, we remapped the programs. We created a fee-based program. The Him Helps program actually we just give them our space, the counselors get our space, if they charge a reduced rate to clients. These are competent counselors who've been vetted by myself through various different methods. We don't really control their practice, but we do kind of know who they are. And it focuses on that medium to high income bracket, which we assessed in Vancouver was between $35,000 and around $55,000 to $60,000 per year. It's an expensive city. So we created that program, and there was immediate results. Within a month, wait times dropped in the free program, the volunteer program, which now centers marginalized groups, to about 4 to 6 weeks wait instead of 16. We're estimating a 300 to 500% increase in total clients seen throughout the year. Happy counselors, happy coaches, reduced barriers, got to keep moving. Essentially, what I want to leave you with is the idea that as programmers, as people in community-based organizations, it's your responsibility to move your programs, not move the population. It's too difficult, and you'll be stymied and you'll hit a cement wall if you're trying to move a population towards you. Move your programs. The programs are things that you can move around. Him Helps is now in the middle there where, yeah, okay, so the people who have maybe higher income, they can probably afford that. They report being really totally fine with paying $50 to $80 per session. And then we've remapped the other programs to be more accessible. That's been some of our work with centering the margins. We are still always learning, always growing. We make mistakes, and we apologize for those. But my friend is going to say a very Vancouver statement here. I was walking to the SkyTrain with my friend on a way to a yoga class, and we were talking about this program, and I was showing my hesitation, and she said, "Aaron, just do it. You've got all the information you need. Just make the jump." We did. No one noticed. highest. So that's what I'll leave you with. Thank you.
Thank you. That was wonderful presentations. We have time for 3 questions. Apologize. 3 questions. So this is a question, for Paul. You talked about sort of the challenge of maybe the need to modify the interventions based on where the guys are located at. But I feel like to a certain extent, we are a little bit still obsessed about the idea of standardized interventions or standardized way of delivering things. How do you reconcile the different needs, but also the wanting to have the standardized programs?
Why did you want a standardized program?
Sorry?
I don't understand why we need a standardized program.
I feel like people often want a standardized program just so that they can compare some of the outcomes with different sites or different. Yeah.
I mean, that's fair enough, but I think our most important goal is to deliver the health care people need. That's the goal. So if it means, I still think you compare between programs. So a program designed for this population is successful or not compared to a different program offered to a different population. So I think the ultimate goal is you have to make sure that people get what they need. So guys living outside urban cores who are closeted, not accessing health care, we can't just take the urban model to them. And it's exactly what Aaron was just saying, right? You have to move your program to your population. So when we go outside the city or when we go to Timmins, we can't take the Ottawa's urban core program to them and expect it to work.
In Ontario, or at least in Toronto, to be Toronto-centric, we've moved from, we're a little bit ahead of some other cities to, if you ask me, a little bit behind a lot of cities in many respects, although we're doing great work as individuals and we have very strong ASOs. There's some coordination that we are not quite as good at yet. And the GMSH is bringing us here together, but only is allowed to do what it's allowed to do. So, and I guess I'm kind of curious, to what extent is a model like him that can go to more than one city and more than one clinic, to what extent is that, how did you basically make that happen? I know, Aaron, I don't know if you were there at the very outset, but, how did that actually happen? And I guess for our Ontario panelists, how viable is that kind of model here? Because I'd really like if we had some sort of model where people actually worked together and could train each other, and it wasn't one organization competing with another organization, and this clinic does this, but this clinic does that, and basically in each part of Toronto, there's different, or each part of the GTA, there's different organizations that do different things, and they're struggling to actually communicate with each other within the GTA. I think the HIM model is something that we really could emulate. So I guess, how did it happen, and then to what extent is this viable, so that we're not just doing one center here and one center here and one center here? Even within the GTA, it could vary neighborhood by neighborhood.
Okay, so thanks, Trevor. Trevor's always trying to flirt with me through him. Actually, we have in the room, Michael Quagg is one of the original board members of HIM, so I want to do a shout out and recognize that I'm not going to fully go into the details of how HIM started, and I might get some stuff wrong, but what I would say is that Vancouver has had a lot of pre-existing infrastructure, and some of that was the harm reduction infrastructure that was already in place. Vancouver it was a harm reduction site already. In many cases, work by Dr. Bruce K. Alexander and the Rat Park experiment through SFU was formative in the 70s and 80s for this kind of notion that actually there are social solutions to complicated health problems. So what I would say is that it was in some ways a perfect storm. There was some really, really strong and intelligent advocates. There was data. There was a kind of a group of people who wouldn't say no. in a way, and they kind of also recognizing the infrastructure of the Community-Based Research Center for Gay Men's Health, which had existed already by the time HIM was formed for at least 12 years. And there were some strong public health experts in there. So data was one thing, the people was another thing, it being a perfect storm was the other thing. There's probably things I'm missing, Michael, but I wasn't there at the beginning. I've been working there for about 3 years now. As far as viability, again, I don't know. But what I can tell you is that there is significant projects launching across Canada that are going to be looking at this. And there's going to be a lot of intentional work being put into this over the next 5 years. And that's going to be collaborating with Health Initiative for Men, Community-Based Research Center for Gay Men's Health, taking the lead on that. So the organization that helped form HIM is taking the lead on a national project. And so it's entirely possible that some kind of major changes are going to happen over the next 5 years. Yay.
And I'd say that probably one of the challenges for Toronto is being such a big city, right? With so many service providers, so many partners, community-based organizations. So it takes a lot more to do that consultation and partnership work. One of the advantages in Ottawa is that it's a smaller size city, and so for our mental health partnership table, we have pretty much all of the main mental health service providers around a room that is a lot smaller than this one. For Toronto, it would take probably this room to have everyone around the table, and with all the challenges of, getting talking things through and deciding what's going to do. So I guess a structure on how communication and consultation would work would be something, a priority to set when thinking about doing that. But I like Vancouver. Not Toronto, but still a bigger city than Ottawa. We inspired ourselves from Vancouver and Montreal to work on gay men's health. So it takes committed community members, committed service providers, and there's a lot of those in Toronto as well. So definitely viable, but I think you have a challenge that no one else in Canada does. So it's just thinking how to overcome that.
Hi, just a quick question for Max. I really liked how you laid out the intake and referral process. I'm very curious about people or consumers, service users' understanding of mental health. So I'm curious about what they call in asking and what's their understanding or expectation around counseling service. Do they have this idea that it'll be short-term, that it'll be long-term? Do they have this perception that it's like one issue that I'm going to work on? So I'm just curious to just hear about the kinds of calls you get and what people's expectations are.
Yeah, so in the intake, we kind of lay all of that out for them. So we let them know that we don't provide direct counseling, that it's going to be a referral. We let them know kind of the extent of what we can do. Not usually, every time I ask what the client's goal is. So what they understand about what the service is and what they expect to get out of it, and where they kind of see themselves going through a referral. I think that's okay.
And I just add to that there's a lot also that, because some of the advertising we don't promote, do you have a mental health problem that you want to talk about, right? We talk about it. Do you want to get connected? Are you feeling lonely, feeling maxed out? So those kinds of questions to spark maybe they might want to get in touch with us. So some come knowing there's something not going right, but they don't know what they want or they need. So a lot of the work with Derek's finding that out. And for some, it might be a lot of them don't come knowing I want long-term psychoanalysis, right? So it's working through that with them.
And some people come in and their expectation is I need to see a psychologist, and really by the end of just chatting for an hour, they feel a little bit more calmed down, and it was just that something was going on that day, and they didn't have anyone to talk to about it. So sometimes people come in and they think they need these referrals, or they're looking for something, and it's like, here's some resources, and I'll send you like referrals because you requested them. But most people, or not most people, some people like feel comfortable just like chatting for an hour, and we let them know of like other things that are going on, just so that we like keep them connected with our services and keep them connected with like events that we're hosting and that we're connected to in the city.
Great. That's it for the afternoon panel. Thanks, everyone.